everybody, and welcome to Includes podcast presented by Proximal Solutions. Before we go into our episode today, there is something that I really need to share with you guys, because if you don't know, you need to know. So if you have not heard about Anchor, guys, it is the easiest way to make a podcast. And I said it is the easiest way because number one, it is free. Yes, it is free. There are also creation tools that are going to allow you to record and edit your podcast right from your phone or your computer. It does not get any easier than that. But wait, there is more. Anchor is also going to distribute your podcast for you so that it can be heard on Spotify, Apple Podcasts, and more. You can even make money from your podcast with no minimum listenership. It is everything really that you need to make a podcast, and it is all in one place. So do me a favor, go in, download the free Anchor app, or go to anchor.fm to get started. Hello, everyone, and welcome once again to another episode of Includes podcast presented by Proximal Solutions. I am your host, Marlegny Mourino, and I am so excited to be here with you all again, another month, another episode. And I know I say that every single month, but really, guys, it is a privilege that I am here and I'm able to do this for you and share all the knowledge. And it is an honor for me to have you all listen to my episode. So thank you all so much for tuning in today, and also for tuning in all of my other previous episodes. If this is your first one, please make sure to check out all my other episodes. So today I have a very interesting topic. It's very interesting for me, so I hope that you find it interesting as well. In a previous life of mine, I had the privilege to work with these type of facilities that I learned so much about and that I love so much. And these are FQHCs, or Federally Qualified Health Centers. So I wanted to share this information with you guys because of the times that we're living in today. You know, with this pandemic, some of you, I know, probably lost your job. Some of you are working from home and maybe don't have the same benefits you had before. So knowing where to go without health insurance, knowing where to go for your healthcare services is crucial. So let's dig a little deeper into FQHCs and what they are. So they are community-based healthcare providers that they actually receive the funds from HRSA's Health Center Program. HRSA is the Health Resources and Services Administration, and they have these funds to provide primary care services in underserved areas. They must meet a stringent set of requirements, including providing care on a sliding fee scale based on the ability to pay and operating under a governing board that includes patients. FQHCs are considered a safety net providers. They may be community health centers, migrant health centers, healthcare for the homeless, health centers for residents of public housing, and also outpatient health programs that are funded by Indian Health Service. So their main purpose, guys, is to enhance the provision of primary care services in underserved urban and rural communities. According to HRSA, once again, the Health Resources and Service Administration's FQHCs qualify for funding under Section 330 of the Public Health Service Act. They qualify for enhanced reimbursement from Medicare and Medicaid, as well as other benefits. They serve an underserved area or population. They have to offer a sliding fee scale, provide comprehensive services either on site or even by arrangement with another provider. And these services include preventive health services, dental services, mental health and substance abuse services, transportation services that are necessary for adequate patient care, and hospital and specialty care. I mean, just amazing, amazing facilities. They have to also have an ongoing quality assurance program and once again have a governing board of directors. So let's take a look at the history of FQHCs. So FQHCs provide, once again, comprehensive primary care services to all individuals, and this is all individuals regardless of their ability to pay. And again, this is why this is so important that for me, and also to have an episode now again with the pandemic that we're having, and people being laid off and losing their health insurance. So their history actually trace back to the neighborhood health centers that emerged from the Lyndon Johnson administration's War on Poverty in 1965. Neighborhood health centers were created at the federal level to provide health and social services in poor and underserved communities. The War on Poverty's community empowerment ideals were advanced through a federal funding model that bypassed state interference and by a management model that incorporated constituent involvement to ensure responsiveness to community needs. Through the 1970s, Congress authorized a separate primary healthcare programs for migrant, homeless, and public housing populations. The Health Centers Consolidation Act of 1996 combined all of those separate authorities, separate plans, or acts into one under Section 330 of the Public Health Service Act. The term federally qualified health centers was created in 1989. Their creation legislation was calculated to address concerns that health centers were using federal grant funds that were intended to support the health care of the uninsured to subsidize treatment for Medicaid patients instead due to state Medicaid payment rates being insufficient to cover the cost of care. Okay, so the FQHC program established preferential cost-based reimbursement for FQHCs under both Medicaid and Medicare. The reimbursement strategy has undergone modifications, but an FQHC is still defined as an outpatient facility that receives federal grant funds under Section 330 of the Public Health Service Act. Community health centers that meet FQHC program qualifications, short of actually receiving those 330, the Section 330 grant, are sometimes called FQHC lookalikes. Okay. Some quick facts and statistics. Health centers play a critical role in the United States healthcare system, delivering care to over 25 million people. That's a lot of people. 25 million people. So from the National Association of Community Health Centers, they created a chart book, is what they call it, back in 2017, where they actually have some statistics and that I'm going to share with you guys. So health centers serve 1 in 13 people in the U.S., including 1 in 6 people receiving Medicaid, 1 in 3 people that are low income and uninsured, 1 in 3 individuals living below the poverty line, 1 in 4 rural Americans. Okay, the income of the patients also fall in different categories. So about 71% of the patients are at 100% of the federal poverty level or below. 15% are at 101 to 150 of the federal poverty level. 7% are at about 151 to 200%, and 8% are at 200% of the federal poverty level. Some other quick facts. The ages of the patients that you see the FQHCs is going to vary, so it's not specific to certain ages. So you have 10% of the patients are under 5 years of age, 14% are ages between 5 and 12 years, 10% are ages between 13 and 19, 7% ages 20 to 24, 27% ages 25 to 44, 24% ages 45 to 64, and 8% ages 65 and over. So all ages under 5 to over 65. Okay. So that's pretty amazing. Most health center patients are publicly insured or also uninsured. And here's the breakdown. So we have about 49% are Medicaid patients. 24% are uninsured, 17% might have some kind of private insurance, 9% Medicare, and then there is a small 1% of other public insurance. So all insurances, all ages, whether you have insurance, whether you don't have insurance, FQHCs are there for you. So let's talk a little bit more about the history. I love history. You know, the history kind of gives us like where we're headed to and where we're going. So America's health centers owe their existence to turn of events in U.S. history and also to a number of determined community health and civil rights activists who fought more than 50 years ago to improve the lives that are in deep poverty and in desperate need of health care. Among those people, there was a young doctor that was also a civil rights activist. His name was Dr. Jack Geiger. While studying in South Africa, he witnessed how a unique community-based healthcare model had brought about astonishing health improvements for some of the poor citizens of that particular country that he was at. Dr. Geiger and other healthcare pioneers submitted this proposal to the Federal Office of Economic Opportunity, and this is kind of what I mentioned a little bit ago, to establish health centers in medically underserved inner cities and rural areas of the country based on the same healthcare that he studied in South Africa. Amazing. So again, knowing the history, seeing what they do and how they help our population is just amazing. So after this, they founded the first two, back then they were called neighborhood health centers, and now they're called Community Health Centers program that was launched. So the first two were one in Boston, Massachusetts, and the other one was in Mound Bayou, Mississippi. Community Health Centers serve as the primary medical home for over 29 people in more than 12,000, yes, 12,000 rural and urban communities across America. Amazing concept. And I know I have listeners that are overseas. So maybe in your countries, you might have some similar type of community health centers. So just again, once again, an amazing, amazing, amazing concept. So how do FQHCs make it different? Well, a difference. If you're not already convinced, FQHCs provide healthcare in medically underserved areas, or MUA, or to medically underserved population, MUP, and that will in turn do several things. It's going to improve access to primary and preventive care. It's going to have cost-effective care. It's going to have high quality of care. The reduced number of health disparities, also effective management of chronic illnesses, improve birth outcomes, and also create jobs and stimulate economic growth. And you're probably thinking, well, how does it do all of that? So let's take a deeper look at each and every one of these. So improve access to primary care and preventive care. So health centers provide preventive services to vulnerable population that would otherwise not have access to certain services such as immunization, health education, mammograms, pap smear, and other screenings. Okay, cost-effective care that is received at health centers is ranked among the most cost-effective. Okay, high quality care. Studies have found that the quality of care provided at health centers is equal to or greater than the quality of care provided elsewhere. Reduction of health disparities. So disparities in health status do not exist among healthcare patients even after controlling for socio-demographic factors. The absence of such disparities at health centers may be related to their cultural sensitivity, practices, and community involvement, features that other primary care settings often lack. So In a state's low-income population that is served by health centers, racial and ethnic health disparities in key areas are reduced across the state. Again, pretty cool. Effective management of chronic illnesses. Health centers meet or exceed nationally accepted practice standards for treatment of chronic conditions. Improve birth outcomes. Health centers also improve access to timely prenatal care. Create jobs and stimulate economic growth. I mean, you have to have staff, right, to run these health centers. So, in addition to healthcare savings, health centers also bring much needed economic benefits to the low income communities they serve. I did a little bit of research, and back in 2009, I know it's been 10 years ago, health centers generated approximately 20 billion in economic activity for the local community. Again, that was 10 years ago. 20 billion. Can you imagine what they're doing right now? Just amazing, amazing, amazing. So FQHCs or community health centers will never turn a patient away. I've already said that a couple of times. By law, health centers may charge no more than a nominal fee to individuals whose incomes are below the federal poverty level. Individuals with incomes between 101 and 200% of the federal poverty level must be charged using a sliding fee scale with discount based on patient, family size, and also income. The slide discount is applied to the gross charges. The percentage of the discount is determined based on the federal poverty guidelines. The sliding fee scale is established in conjunction with the federal poverty guidelines. So again, you're looking at your income, your family size to determine that. How does a facility or an office become an FQHC? So in a nutshell, once the clinic gets the 330 grant, they become what it's called a community health center. Okay. Then they submit a cost report to Medicare once a year. This is going to set the fixed rate for the clinic, which is called the PPS or Prospective Payment System. Also, you hear it called Enhanced Reimbursement Rate. Once the report is turned in, the health center would receive a letter from CMS stating the PPS rate, or once again, Prospective Payment System rate, and now the health center is considered an FQHC. Pretty cool, right? But they have to meet certain qualifications, okay? It's not just, you submit a paper and you're good to go. You have to meet certain qualifications. So in order to qualify for federal support as a health center, an organization must provide comprehensive services and have an ongoing quality assurance program, including an annual review, meet all health and safety requirements, serve a designated medically underserved area or MUA or medically underserved population MUP. Once again, offer a sliding fee scale to persons with incomes below 200% of the federal poverty guidelines. Be governed by a board of directors where the majority of the members get care at the FQHC, so actual patients. They also have to offer services to all persons regardless of their ability to pay. Be a nonprofit or a public organization. Be community-based. Okay. Serve, once again, medically underserved. I can't say that enough. And provide all of those comprehensive primary care services. And this is per CMS. FQHC visits must be medically necessary. They must be face-to-face medical or mental health visits or qualified preventive health visits between the patient and an FQHC practitioner. And the practitioner gives one or more qualified FQHC services. In certain limited situations, include a registered nurse or even a licensed practical nurse visit to a homebound patient. They must, under certain conditions, a qualified practitioner give outpatient services when the FQHC meets the relevant program requirements to provide these services. FQHC's visits may take place in an FQHC at the patient's home, including an assisted living facility, a Medicare covered Part A skilled nursing facility, and also at the scene of an accident. FQHC's visits cannot take place at an inpatient or outpatient hospital department, including a critical access hospital, or at a facility with specific requirements that exclude for FQHC visits. So again, it's very very detailed. There are benefits from being an FQHC, so a per visit bundle payment that is based on historical cost for services provided under Medicare, reimbursement under the PPS rate or prospective payment system or other state approved alternate payment methodology for services provided under Medicaid, eligibility to purchase prescription and non-prescription medications for outpatients at reduced cost through the 340B drug pricing program, access to the Vaccine for Children program, eligibility for various other federal grants and programs, grant funding also for new grantees, funding up to $650,000 can be requested, and medical malpractice coverage is provided. Very important for health center organization, their employees, and eligible contractors under the Federal Tort Claims Act. So what about billing and coding for FQHCs? Okay, so FQHCs are reimbursed at a flat prospective payment system rate for each face-to-face visit with Medicare and Medicaid eligible patients, okay, which is much higher rate as compared to non-FQHC practices and physicians, but remember that they must also operate that sliding fee for the uninsured. Patients complete a financial assessment that is based on the federal poverty guidelines to determine if they are eligible to receive those discounted services. Because of an increased reimbursement, there are billing stipulations that must be followed. The stipulations, guys, they can be tricky. And, for somebody like me, for example, that when I started working with FQHCs, I had only done billing and coding for traditional non-FQHC physicians. It was a bit of a learning curve for me, okay? So FQHC rate services, once again, must be face-to-face. And for Medicare, for services that are bundled with code T, letter T as in Tom, 1015. This is your clinic visit encounter, all inclusive for Medicaid. Okay? Medicaid will also reimburse for the following services when reported in conjunction with the HCPCS code T 1015, and those services are laboratory services, pharmacy services, x-ray services. Okay? Now, on the other hand, for Medicare claims, there are encounter codes that we need to add to the claim that are very specific to FQHCs. And you have G as in goat, 0466, this is for new patient. G0467, this is for established patient. G0468, initial preventive physical examination, or your IPPE, or your annual wellness visit, AWB. G0469, this is for new mental health. G0470, this is for established patient mental health, along with services provided for the day. Okay, so we're sending a different set of codes that you would normally send for, that you don't normally send for non-FQHC physicians. Now, there are certain services that can be billed for payment outside of the PPS rate, and that may include the technical component of FQHC services, certain laboratory services, durable medical equipment, ambulance services, telehealth. Yes, telehealth, real big now with the pandemic. Hospice services and group services. So, again, billing for this at the beginning when you first start coding for FQHCs or billing for FQHCs, like, oh my God, this is a little bit different. Now, another thing is that there are specific payer requirements when you're submitting the claim too. So, most payers are going to want, most will want these services billed on a UBO4. Okay, and then non-qualifying visits on a CMS 1500 form, which you don't see that for non-FQHCs. However, there may be times when a payer dictates that for all services in an FQHC to be billed on the CMS 1500 form. So with the UBO4 form, you have another certain things that you also need to understand, like for example revenue codes that are needed to be added to the UBO4 to be able to build those codes, and that's going to vary based on the type of your visit, as well as making it essential to have we need to be able to differentiate which claim are we sending, which form are we using, which payer, what are they wanting. So this is something that, again, it's really important because just the different type of facilities, even for new billers and coders, if you went to school, this is something that you might not learn in school. So again, it was a learning curve for me. There are amazing facilities that exist out there, and that I believe that we all need to know what they are and even where is the closest one to you. So they're all throughout the United States. You can go to Find a Health Center. Once again, Find a Health Center HRSA.gov. I want to say that one more time. Find a Health Center HRSA.gov. And by going to that website, you can put your zip code or your town, and you're able to find which one is the closest one to you. So one of the things that I'm going to do for you guys, I think I've done it from all of my episodes, I'm going to leave you a list of resources where you're able to look up more information about FQHCs, where they are, what they do, and also some information on the Primary Care Association. Like every state has their Primary Care Association to work with FQHCs, and I've been privileged enough that I had the chance to work with Florida's and also the one in Oklahoma, and actually had the chance to learn and also meet so many FQHCs in Oklahoma and do training for them as well, especially when we were switching from ICD-9 to ICD-10. So again, FQHCs, I have them in my heart forever. I know, you might know somebody right now that might need to go to one of these type of facilities, but they are there, they're available for you, and they are amazing. So please go check out which one is the closest one to you. Let me know, if you have seen them, if you know what they are. Let me know if you have any questions, if you want to dig deeper, even into, billing and coding for FQHCs. I can do that with you. But that is all I have for you guys today. So thank you all so much for listening, and I will catch you in our next episode. Thank you guys.